Welcome to the Head and Neck Cancer 2020 video series, presented by St Vincent's Hospital Sydney, the Kinghorn Cancer Centre and St Vincent's Private Hospital Sydney. Managing Distress and Recovery with Dr Ben Britton and Associate Professor Haryana Dhillon.
Hello, my name's McCrossin and welcome to this video about managing distress with head and neck cancer patients. 7 years ago, I was treated for stage 4 throat cancer, oropharyngeal it's called, but it was in my throat, tonsils and the back of my tongue, and I was treated with radiation and chemo, and I'm still here. And this video on managing distress is one of a series of videos looking at innovations in treatment for head and neck cancer patients to both improve survival, but equally importantly, quality of life. And these videos are hosted by St Vincent's Hospital Sydney and the Kinghorn Cancer Centre. And before we begin, I'd like to acknowledge that we're broadcasting today on Aboriginal land, and to acknowledge the Gadigal people of the Eora Nation, their elders past and present, and emerging leaders, and also to acknowledge that many Aboriginal and Torres Strait Islander people are disproportionately affected by the sort of head and neck cancers that we're talking about today. So, in just a moment, you're going to hear just a little bit of the story of 3 very different head and neck cancer patients, and then we'll meet 4 clinicians, 3 of whom are working on a daily basis with patients and families, and one of whom is doing important research. So, welcome and thanks for joining us.
Maureen Johnson from Head and Neck Cancer Support Aotearoa, New Zealand again. Julie has asked me to talk about mental health and head and neck cancer. And I could go on about this for ages because I've had 3 bouts of head and neck cancer, getting more disfigured and disabled each time, but still here. And I have boiled down my thoughts as a long-term patient on mental health issues, and I've come up with 3 things I think are important to me as a patient and to carers who live through this situation with their spouses, partners, etc. The first one is medication. I don't know if all patients realise that there are useful medications that can reduce the pain, the grief, the anxiety and the fear and the panic. There are anti-anxiety medications, which I have never been offered, never taken. Fortunately, I probably haven't needed them, but antidepressants have served me very well indeed. Citalopram to keep me thinking a bit more positively, not being in that dull, aching, panic, anxiety-ridden mode long term. I think they've helped together with my second piece of advice or strategy, which is seeing a counsellor, a psychologist or a psychiatrist. I don't know if all patients, especially men, accept that this is just a practical, helpful aid to coping with a cancer that is so isolating, disfiguring, so has such terrible treatment over many weeks that can leave you pretty emotionally scarred. So I think that normalising psychological help is a very good thing. It's happening now. It can't happen fast enough. And I found that I have had free counselling from Cancer Society psychologists, and they've helped me to sort out what is rational fear from what is exaggerated irrational fear, and they've given me strategies like mindfulness, like things like taking photographs of nature and sharing them, gratitude for the things that are good in our lives, taking things a step at a time and not catastrophizing when you don't need to. And just the intimacy of strangers, your friends and family, can't really deal with all your grief. It needs a stranger to look at it in perspective and help you in a, what could I call, maybe in a, seeing it more clearly perhaps and putting it in perspective with what most patients feel and what are the best ways to deal with it. My third method of dealing with the grief, pain, depression, anxiety of head and neck cancer is peer support. This is maybe should be top of the list. When I first got head and neck cancer, I was so worried that I'd be so disfigured, or so disgusting that I'd be isolated, my life would be over even if I survived, that I joined the Oral Cancer Foundation in America, and they helped me hugely. A big pool of experienced patients, some of them with excellent peer support skills, and tons of information. And now we have the Aotearoa group, a Facebook group, and for all Facebook sins, this has been a great group for me to help manage, because it's not only getting support from your peers, but giving it that helps ease the troubled soul. So those are the three things that I've boiled it down to for dealing with mental health issues, and there'll be many more, and they don't work for everyone. But I hope that gives some focus for discussion. Thank you.
Hi, I'm Denise Whelan, and I was diagnosed with squamous cell carcinoma in my upper gums and under one lip in May 2017. But on the day I found out that I had cancer in my gums, I was alone. I took a phone call from the lovely oral surgeon who'd done the biopsy the week before, and I think I sensed that the news was not going to be great. So whilst I had a teary reaction and was able to summon my husband back home from the work he was doing as a volunteer, I actually then, my head went into a different space. It went into the organiser that I am, the planner that I am, as I started to seek where I would be having a consultation. In fact, it was the very next day at Chris O'Brien Lifehouse with my surgeon, who was, and still is, Professor Jonathan Clark. Getting there, though, was the hard part. You see, my anxiety still had a great hold on me, and I was fearful of the drive. It was to Sydney for 2 hours. I was scared about my IBS that may have impacted me. But my husband, who was amazingly patient, still is, and my GP just said, Denise, you know you've got to do it. And in fact, I did do it. I did it with lots of help. I used some medication, and I got to Chris O'Brien Lifehouse to hear the story of what was ahead, the surgery that would end up taking 11 hours. Once I knew what was ahead of me, scared as I was of the idea that I would lose the upper part of my mouth, I had to trust, and I did trust, in the team that was going to look after me. As someone who, like many, wants to be in control of everything, I realised this was something I couldn't actually control, and that the only thing I could control was me and my reactions. So I needed to embed some mindfulness practice, which I was already doing, but I needed to increase that, and I needed to use some distractions and so on as I waited the long 7 weeks before I finally had that surgery. As a teacher and a talker and an eater and a smiler, it was incredibly important for me to hope that I could have all the skills that I valued, such as talking, eating, drinking, and smiling. And in fact, when I recovered from the 11 hours of the pretty drastic reconstructive surgery, my first words were, "Oh, I can talk." That was incredibly powerful and empowering. I then recovered over the next 10 days at Chris O'Brien Lifehouse, and each person, each medical person, each support person who came to see me went, "Wow, you're looking good." By their comments and by how I felt inside, I knew that I was on my way to wellness, even though it was one heck of a journey, and I knew it would take a very long time. Using those skills over the next 2.5 to actually 3 years now has become a practice. In fact, my mental health has never been better. I do, though, have to keep check of down days, and I have to remain patient as I wait in between surgeries. I've now had 4, but I am going extremely well. One thing that I stand by is having a routine. I was pretty routine-less in my early years of retirement, but having a routine, something to look forward to, something creative to do every day, something social to do every day, which is when I go out for a cup of coffee and get myself dressed up to do so, has made the world of difference. I hope that sharing my story might help others know that having a cancer diagnosis, particularly one that's in the head and neck, may not necessarily be all doom and gloom. It may be a chance to grow.
Hello, my name's Garry Mar and I'm a head and neck cancer patient. I had 8 weeks of radiation, chemotherapy, PEEK tube and the mask. Very stressful times. I didn't cope very well. Took a psychologist, psychiatrist and my own biopsy doctor to keep motivating me and helping me and encourage me to keep going because I gave up many times. I want to talk about the distress, and I want to give a suggestion to help people get through. Because the doctors and nurses, they kept telling me to do these things, to keep trying to feed myself through the PEEK tube and other things, and I just could not do it. And I asked if I could talk to another patient just to get some ideas and help as to how they cope. And their answer was, for privacy reasons, they couldn't give me any names of anyone else I could talk to. It's a very lonely journey when there's nobody to contact, to relate. And it's a very difficult struggle. Later on down the track, a couple years down the track, I found a flyer for a head and neck cancer support group in the Central Coast. And I went to that meeting and lo and behold, met hordes of people that underwent the same thing as me. And we all shared a lot of good suggestions about how they coped through the scenarios, the mask and the PEEK tube, the feeding and all this stuff. I only wish I had that at that time. And so my suggestion is for all doctors and nurses in the cancer centres to recommend new patients to get in contact with support groups at the very early stage, because during the time when they really need it, at least they've got that contact and they can go through and talk to people. And to summarise, the difference is the difference between sympathy and empathy. The doctors and nurses can give you sympathy. They go through a script of telling you what to do, and when you throw things back, I can't do that, I don't know what to do, and they can't help you. They really can't. But other patients have been through it, they can give you empathy. And it's empathy that is really valuable. They know what's going on in here, they know what's going on in your heart, and they can relate to you. And they've had all that experience that within the group, they can give you so much tips and ideas of how to get through. It's so valuable. So my innovation recommendation is for all doctors and nurses to promote and push support groups. They're very valuable. For head and neck, beyond 5, they have a whole list of all the support groups that currently are available, and we'll keep adding to that list as more and more support groups evolve. And for other cancer groups, obviously the Cancer Centre, they can definitely help. Thank you.
So look, let's begin. It's my enormous pleasure to welcome Dr Ben Britton and also Haryana Dhillon. Ben, can I start with you? Do you want to introduce yourself?
Sure. So I'm Ben. I'm a psychologist. I live and work in Newcastle. And I suppose my experience with head and neck cancer patients has been working clinically for a long time, but also done quite a bit of research, and that tended to be the group that I work with in terms of research. And
I'd like to come to that research later, but we've just seen a little bit of the story of 3 people. My first question to you is, what are some of the sources of distress, the causes of distress for head and neck cancer patients? just from what we've heard so far, what came to your attention?
Yeah, I mean, I think what stood out for me is the lady from New Zealand sort of mentioning, and indeed the other lady, talking about changes to what makes their life feel good, meaningful, so talking and eating and socialising, that everyday stuff. And I think the impact on everyday living, on what we usually do to cope, what we usually do to enjoy ourselves and make life feel worthwhile is really impacted on by head and neck cancer, both the cancer but also the treatment. You know, it's quite a rough treatment in that sense.
Just in a nutshell, for someone who might be a new member of a clinical team and they're just beginning to work with head and neck cancer patients, just in a nutshell, why is it considered a rough treatment?
Well, I mean, I think both the level of obvious disfigurement or potential for obvious disfigurement in the surgery is probably disproportionately high in head and neck cancer. And I think also the changes in functioning, both from surgery and from radiotherapy, are disproportionately high. There are just a lot of things going on in your head, and there's a lot to be affected. So eating, breathing, talking, swallowing, communicating, there's just a lot that happens in there, and it's very hard to spare the remaining bits, the non-cancerous bits.
You know, I've visited your hospital, Calvary Mater in Newcastle, north of Sydney, and I had the impression you get quite a lot of head and neck cancer patients. We're talking about managing distress. How do you know if a patient is distressed and needs extra help? And given the nature of this tough treatment, does everybody need help to some degree?
Do you know what? My response, I think, is it doesn't matter if you know, you've got to deal with whoever's in front of you in that moment. So we have screening programs that...
What does that mean?
What does that mean? What that means, let me tell you. We have screening programs that are designed to pick up people who are meeting sort of clinical levels of distress, and that might lead to an anxiety disorder or a mood disorder, or depression, something like that. But one of the things I think is really important, and one of the things we're trying to do, is train everyone, not just the psychosocial people, to be able to deal with whatever distress they're presenting within that moment. Because I think, as you say, probably everyone needs to at least have their distress addressed. And that doesn't necessarily mean everyone has a mental illness or even needs to see a mental health professional. But I think one of the important things, and this really is the other thing that struck me, was the gentleman, Garry, was saying, you know, the doctors and nurses, they can't empathise with that stuff. I think, you know, it's one of those things that a lot of the technical specialties can get so caught up in the job that they're trying to do, which is very important, and they do need to concentrate. But sometimes they can give the impression they can't empathise and can't connect and can't deal with distress even when it's sitting right in front of them. So groups like the doctors and nurses, but also radiation therapists and all of allied health, dietitians, speechies are particularly important in this group. There's a lot of stuff that can be done where we're not talking, they don't have to be specialists in mental health to deal with someone's distress in that moment. And that will be almost everyone.
Can I now turn just to you?
Yeah.
Give us 2 or 3 brief examples of what you actually do as a senior clinical psychologist. If someone is referred to you by a speech pathologist, a dietitian, a radiation therapist, a nurse, just concisely, what's the sort of help? Someone could be watching this. Should I go to the clinical psychologist? You tell me.
Yes, they should.
Why?
We are problem solvers, and so what I do is broadly what our job is to help people build a better or worthwhile life. And so what you do is initially find out what is getting in the way of that. Why do they feel their life is somehow really hard, as Garry said? Is it beginning to feel not worthwhile to them? And then using all of our background and all of our knowledge, build something for them specifically. So
be specific. Give me an example. When you say
some people do really need that social support, and some people, as Garry said, a support group is the key that unlocks everything. Some other people, though, are very, very private, and it might be something about eating in front of their grandchildren, so they don't want to scare their grandchildren. So I had one lady, that was an issue. And so it was about overcoming that, and that was very much a very behaviourist approach, which is literally exposure, practicing a little bit at a time, starting with small things, moving up into something more difficult, more challenging for her, and noticing that their reaction wasn't to run away from grandma.
Could I just check I understand that you encourage this person to eat in front of their grandchildren, something easier and then getting harder and harder, so it could be potentially more messy or more dribbling, and just get more confident about eating in front of their grandchildren?
100%, if that is the issue. Okay, but the real difficulty with psychological strategies is that nothing works for everyone. And so anything that works for one person may not work for everyone. And so really, the way to see this is we're just tradies, and you need to come and see the trade person, and if it doesn't work, the first thing doesn't fix your problem, you need to keep going and have another solution and try something else, because not everything works for everyone.
I just want to ask you, there's both the help you might need during treatment. I personally, when I had radiation therapy, 30 sessions, saw a psychologist to help me cope with panicky feelings I had inside the mask by giving me something to think about.
Yeah.
But there's also people who can be distressed some years later. So, again, just briefly, how available is the psychologist in the cancer team, wherever people watching this are getting their treatment? Is it just in the first few weeks, or can we have access to you later? What's it like in your situation?
In ours, it's unlimited. So if you've ever had any contact with the Marr, the psycho-oncology service is available to you, including your family and carers, even after someone passes away. So it's a very open service and very supportive. I'm not sure, I can't speak for others, but I think it's worth asking. Wherever you are, it's worth asking, because you might be surprised how available it is.
Should this be the single most important message out of this video for patients at the moment, or people who are recovering? Ask for help if you need it. Find out what's available. Ask.
100%. Yeah. I think, see it as problems to solve. And, one of the ladies mentioned, blokes being reticent to speak to someone. But, as I say, if you've got something wrong with your toilet, you get a plumber. So see it as a problem to solve. Do you know what I mean? And that can be really helpful for blokes to just say, well, look, I'm feeling this way, or I'm having trouble with this, I'm avoiding that. And it's getting in the way of living a good life for me, so do something about it. And that's the trade to see.
I'll come to Haryana Dhillon now, but I love the idea of a tradie.
Yeah.
I think that's a very helpful analogy, and you've got a toolbox with help in it. It's very interesting. But Haryana Dhillon, can you introduce yourself and tell us what you do?
Sure. So I'm a behavioural scientist at the University of Sydney, and I work only in research, but most of my research is really around what are the experiences of people with cancer, and including head and neck cancer, and how we might sort of help them deal with that and live the lives that they want to. I guess a lot of what I do is around that sort of putting the patient, the person with the illness, at the centre of the problem, and trying to work out how we make the systems work better, and also to support those people.
Before I ask you about a couple of bits of current or recent research that you think offers us some insight into this managing distress, I guess I'm interested in your sort of overview of, do you think our health system gives equal attention and care to the emotional impact of cancer as it does to the physical?
Yeah, it's a great question, Julie, and I think the short answer is no. So we're very focused on disease sites and the diseases that people have and where that happens in their body, and we're not looking at that as a whole of system problem, and really that's the impact of the illness on people emotionally, on their lives and how they live them. And I think we really need to look much more holistically at how different illnesses and treatments have an impact on everyone's all of everyone's life, all of those aspects, and they're all equally important to the person living with that illness.
Tell us about a couple of bits of research that you think will inform both the patients and the family and also the clinicians watching this about head and neck cancer and distress.
So I think there are a couple of things that really we're very focused at the moment, and a lot of the work that we're doing around the impact of the mask and how we try and minimise that impact, because it's obviously, as you heard from Garry in the video, how distressing having to have that mask, which is really there to keep him safe, but also actually meant that he couldn't move during the treatment, and what that felt like for him. So
could I just say, just for anyone who might be right at the beginning of their cancer experience, that the mask is a personally created way to hold your head still while you have radiation therapy to tumours that might be in the head and neck. So it's really a safety mask to keep you still, but for some people it can be a claustrophobic experience to varying degrees of intensity, whereas other people aren't bothered by it at all. So that's the mask. But Garry kept going, the mask. You had a sense that it was hard for him. But yes, go on, tell us about the work.
Really interesting, and people don't necessarily know what their reaction to the mask is going to be until it happens. And it can vary over time, and we're not very good at actually predicting or working out who is going to find the mask difficult to deal with when they first start their treatment, or the people for whom it's going to get more difficult over time. And so I think we need to be much more aware of that. So actually being able to screen for the kind of experience that people have, to ask them about how they're finding it and what the experience is, rather than waiting until someone is in extreme distress and really finding it very difficult to cope with treatment before we start to help them with that. Because as Ben's already alluded to, we've got lots of tools that we think can help with that, and they're going to be different for different people, and it might be different at different stages. So it may be things like one of the studies where we had interviewed people who've had an experience with the mask. They told us about the things that they did while they were having the treatment to help them cope with that. And that for some of them it was singing songs that they knew, or listening to music that they knew was the right duration for how long their treatment would take. It might have been counting the number of times the machine had clicked over, and just kind of sometimes very simple things like that, but enough to take the focus away from what they're feeling and in the mask, and distract them from that a little bit.
And in that research, did people talk about asking for mild sedation, Ativan or Valium or something of like that nature?
They sure did. And some people, for some people, they use that all the way through their radiation treatment because they didn't feel that they could cope with it without it. But that has other knock-on effects for their daily life, and coming into radiation every day, it means that they then can't drive themselves home most of the time and things like that. So it has an impact on the support that they need in practical terms. Other people were fine to start with, but really felt that as things became more challenging because they were experiencing more symptoms, they actually needed more support then. And other people tried it once or used it for 1 or 2 sessions, and then actually felt that they'd adjusted and they knew what was going to happen, and they felt that they could cope with it without that. So, it's not the same pattern of use of any of these kinds of tools that you've got for any one individual. It's going to be different for each person.
I think you've done research as well into clinical staff working with head and neck cancer patients and the mask. Can you tell us about that and key lessons?
Yeah, so I think some of the work that we've done there is really that people feel very prepared to deal with what the response is, so that they know that some people are going to have difficulty, but the systems that they're working in terms of the time constraints, and that they've got a backlog of people who are waiting to come into treatment, means that they don't feel that they've got the time to take to deliver the support that perhaps they think people might benefit from. And they also just, a lot of the time, many of our allied health and medical colleagues are not trained specifically in dealing with emotion and communicating with people and responding to those sorts of situations. So I think the work that Ben was talking about, it actually helping everyone else in the team to develop the skills to respond appropriately, in that moment can make a huge difference to people. And that was certainly some of the things that came through very clearly when we talked to health professionals.
I'd love you to talk about whatever research you feel is most relevant, but the question I have, because I really only have time for one more example, unfortunately, is longer-term survival. People these days talk about survivorship. You very rarely hear the term rehabilitation. Whereas in some other medical areas, if you have a stroke, people do talk about your emotional rehabilitation as much as your physical rehabilitation. So where are we up to in our thinking about rehabilitation, and what is this word survivorship? Where are we going in the future, the research you want to see, the change you hope to see?
So you've hit on one of my pet topics, Julie. So I could talk about this for hours, but I think survivorship really is referring to what happens after your diagnosis. And we've kind of had this very limited perception of survivorship as being when you've finished your treatment. And that's changing quite significantly, particularly because we have people who are in lots of different tumour groups who are living longer term with metastatic disease, so advanced cancer. And what that has tended to do is then start to make us think more about what's needed to support someone in their environment. And so rehabilitation is not a word that you hear very commonly in cancer. We talk about you treat the cancer and you manage the cancer, but we don't then rehabilitate the person. So this is really a new area for us, a new way of thinking. And I think we need that focus on what does someone need in the first month, the first 3 months, and the first 6 months after they've finished a particular type of treatment to help them get to the level of function that they had previously or to be as well as they can. And the other thing that I think is really interesting about survivorship, often you'll hear this term, the new normal. And that's one that worries me quite a lot, because I think sometimes the implication is when you talk about the new normal that people take away and go, well, this is what my life is like now. And they think that things cannot be improved and that it can't get better. And what I think is really important is that we make it clear that whatever situation you're in now, there are things that we can do to deal with whatever the problem is that you're experiencing, whether that's a physical problem or an emotional problem. We want to pull out Ben's tools and apply those to make someone's life as the best that it can. And I guess the other area that I think is really worth highlighting in relation to that is the fantastic work that the Cancer Council does. And so again, the helpline number, the 13 11 20, is a place that you can go to find out about a range of different sorts of interventions that are available in the community. And I think one of the challenges for health professionals is actually being aware of all of the things that are happening in community. And so I think that's a really important thing for people who are living with the disease or living beyond it to actually understand this is where you can go to sort of tap into some of the things that you may not hear about otherwise.
Thank you. I'm just going to make a comment, and then I'd love to hear from you, Ben, and then from Haryana about it. Before we move to two other people who are also working with head and neck cancer patients to try and help them manage distress. And I'm 7 years since treatment. I'm immensely grateful that I'm alive, and I was treated with radiation and chemo, and I don't have external scarring. In that 7-year period, I've come back to this building we're in because these videos are hosted by St Vincent's Hospital Sydney and the Kinghorn Cancer Centre, and we're sitting there now. I've come back here many times. I've had all sorts of tests. I've had things called PET scans that check if there's cancer in me. But I haven't had a single person ask me, have you managed to have a sexual life again? Have you managed to kiss? And I haven't had anyone say, how are you coping with the fear of recurrence, the fear that it will come back? I'm actually not meaning to complain. I'm more astonished by it. Fortunately, I do know about Cancer Council 13 11 20, and I have rung them and I have got help. But it's what will it take to change the mindset of our multidisciplinary teams? Most of us are so grateful for their work, that they deal with our emotional and sexual life as much as our physical recovery.
That's a very good question. What will it take? I believe... So part of the problem is specialisation. Everyone has got very specialised, and I think a lot of the teams feel that that's Ben's job. Ben will ask those questions, so I don't need to. And that's fine, except I don't see everybody, and they do. So I think it's about generalisation, less specialisation, and the way to do that, you're saying what will it take? This is just my opinion, but I think, and we've had some good gains in this area, is if you can show how understanding about the patient's mental state, understanding about their sexuality and any other elements that make their life feel really worthwhile and important to them, how they impact on the very narrow medical thing they're interested in, because we know it does. If you can make that therefore part of looking after this narrow thing, suddenly they have to widen their view and say, I also need to look after and ask about these other things. That's, I think, how, when you're asking what will it take, I think it'll take that, to share responsibility via linking to the thing that they already feel responsible for.
Thanks, Ben. Thank you. What about you, Haryana?
Well, I think I would largely agree with what Ben's saying, and I think I would really add that the best person to deal with a particular problem for a patient and to help them find the right tools is the person that the patient connects with about that problem. And so that sometimes is not going to be Ben or me or someone from the psychosocial team. It may be the radiation therapist, or it may be the nurse or the dietitian who is dealing with that problem. So trying to make sure that those people are confident in their skills to respond to those questions is really important, and then also giving them a pathway. So if they find that someone is asking them about a problem that they're not confident to deal with, or they've kind of reached the limit of their knowledge, then they've got somewhere to say, well, actually, I can't, this is beyond my skill level, so let me take you to the next person and make sure that referral happens. So those kinds of clinical pathways are incredibly invaluable for providing really practical guidance to people in their own hospitals and systems about what's available.
Both takes confidence, doesn't it? Because either you have the confidence to have the conversation, or the confidence not to just close your ears and pretend it didn't happen and do something about it.
Yeah, and I think if I can just add, one of the big challenges for us is that we're, as professionals, we're all wanting to know the answer to the question, and there's some of these things we don't know, and I'm going like, I don't know that I can fix this problem for you, but we can certainly help with some tools around that. And sometimes there isn't a solution, but most of the time it'll be something that we can do to alleviate it a little bit. So having the confidence also to say, actually, I have no idea, but let me find out.
Look, Ben Britton, Haryana Dhillon, thank you so much. And I'll just let you know that we've got two more very interesting people who work directly with head and neck cancer patients coming up shortly.
Head and neck cancer, treatment innovations, improving survival and quality of life. Providing up-to-date, evidence-based information for everyone in the head and neck cancer community. Presented by Julie McCrossin, a head and neck cancer survivor. Media production by Daniel Taylor at Insight IT. Celebrating World Head and Neck Cancer Day, 27th of July, 2020. Innovations in surgery, radiation therapy, chemotherapy, immunotherapy, dental care, managing distress and recovery, managing mask anxiety, remove the mask research, Aboriginal and Torres Strait Islander patients, family and community. Discussions of innovations that are improving survival and quality of life for patients with head and neck cancers. The 2020 Head and Neck Cancer video series. Presented by St Vincent's Hospital Sydney, the Kinghorn Cancer Centre and St Vincent's Private Hospital Sydney.